Hello everyone, my name's Eileen Regan. I'm the CCO at Examen, and it's my pleasure to welcome you to the fourth webinar in our 2022 Male Fertility series. As you may know, the webinars take place on a monthly basis, and we're joined by a range of experts in their field across a variety of therapies and treatments. So the event is free and open to everyone. We have a wide range of participants joining us, from academics, healthcare professionals, fertility, wellness specialists, as well as some of the men, couples or individuals on their own fertility journey. Just to say that the views presented in these webinars are the views of our speakers and not necessarily of our company Examen. So we're delighted to have you join us today, and please let me introduce you to our speakers. So this month we are joined by Professor Christopher Barratt. Professor Barratt is head of the Division of Postgraduate Medicine at the Medical School, head of the Reproductive Medicine Group at the University of Dundee, as well as a clinical scientist with NHS Tayside. His formative postdoctoral studies in ART experience was gained at the University of Sheffield with Ian Cook, where they specialised in natural cycle IVF. And from 1987 to 2005, he was the scientific director of the ART Centre at the Birmingham Women's Hospital. He is regularly invited speaker at national and international scientific conferences and workshops, and he was a member of the WHO Male Fertility Semen Analysis Task Force for both the 4th and 5th editions, and director of the WHO 2012 to 2017 Male Fertility Expert Working Group, which devised a new system for the diagnosis and treatment of the infertile male. He was a member of the Human Fertilization and Embryology Authority, HFEA, for 6 years until 2009, and he was appointed to the editorial board of the WHO for development of the new Semen Analysis Manual and the recently published global WHO guidelines for semen reference ranges. Our chair tonight is Professor Sheena Lewis, who is the founder and CEO of Examen and an honorary professor of Queen's University Belfast, where for the past 25 years she has dedicated her research into novel tests for male infertility. She is currently an executive member of the Association of Reproductive and Clinical Scientists and chair of its Scientific Advisory Committee. She has published over 100 full papers, as well as numerous book chapters and reviews. She has been past chair of the British Andrology Society, UK National Representative and chair of the Andrology Special Interest Group of the European Society of Human Reproduction and Embryology, executive member of the British Fertility Society, and was a founder member and vice chair of the Irish Fertility Society. Professor Lewis's research has led to the formation of the company Examen, where we market the Exact test, which is now the market leader for sperm DNA fragmentation testing in the UK and Ireland. So before I hand over to Professor Lewis to welcome you this evening, I just want to run through some housekeeping. So just please do pose any questions through the Q&A panel. So we'll reserve the chat function if you've any technical difficulties, and we'll do our best to help you. But if you could use the Q&A, that allows you to rate the questions, and also gives Professor Lewis the opportunity to chair the questions during the Q&A session. So as I said, if you experience any technical issues, use the chat and we'll do our very best to help you through it. Attendees are muted throughout and the video is enabled for our speakers only. And all events in the series are recorded and will be available on the events page of the examenlab.com website following each session, so you can watch any of the past events you may have missed, or if you can't join the whole thing, it'll be there for you. So it'll give us 24 hours for the recording to be available. And finally, 1 CPD point will be awarded for attendees for the 1-hour event, and a certificate will be circulated a few days after the event. If we could also ask you to rate the event at the end, please do so, as we welcome your feedback and any suggestions. So without further ado, I will now hand over to our chair, Professor Sheena Lewis, to start the session.
Good evening, everyone. It's a pleasure to have you with us this evening, and thank you very much for your time. Thank you for spending time talking to us at the end of a busy day, because I know how tiring work can be, and now that the sunshine is out, I know there are lots of temptations not to come on a Zoom, but we hope that we'll be able to make it well worth your while to be with us this evening. The purpose of these webinars is to raise the awareness of male infertility, because there's so many people who don't know anything about it. And even men who are experiencing fertility problems themselves don't know a lot. So this is an opportunity to provide men with knowledge about advanced testing. And our purpose is really to help more men become dads. The mission and purpose of our whole company is to demonstrate that couple care can improve live birth rates, and also to demonstrate through the research that we do that optimizing sperm health improves fertility outcomes. So we've got a really big purpose, and that's to help 1 million men on their fertility journey. Now, whether or not we're going to achieve that, I don't know, but nobody can accuse us of not being ambitious. So that's what we want to do. So we have a big evidence base for our test. And of course, that's very important to us because I've been a professor for many years in Queen's University, which is a Russell Group university. And I wouldn't dream of putting a test on the market that I couldn't stand over and believe in. So the test is based on 25 years of non-commercial research, which has been supported by research councils. And we have looked into a number of prescription drugs and infertility. We've looked at cannabinoids as a biomarker of fertility. And I wish I was 20 years younger because I would love to take that forward. I think cannabinoids are a very exciting area. And we published a number of papers on that. We looked at pentoxifylline as a motility enhancer, which was being used in many fertility clinics, but unfortunately it had not so good side effects on embryo development. So that has been discontinued. We looked at diabetes and fertility impairment, vasectomy reversals. Men and miscarriage is something that we're particularly interested in at the moment, and I'll talk a little bit more about that. And of course, DNA damage and unexplained infertility, because 25 to 30% of couples get a diagnosis of unexplained infertility, and that's no use to either them or to the clinicians who give it to them. So we have ongoing research into men and into their sperm, because one of the things I hate is when people say men are just sperm donors. Men are human beings in their own right with all sorts of other issues and problems in their lives. And we need to look at them as whole people and look at their bodies, not just their sperm. So we're looking into varicoceles and their repair, and we've got some very exciting data on that, which we're working on with King's College in London. We're looking into infection, and we're looking into the microbiome, which is one of the trendy buzzwords, and we'll hear a lot more about that in the next few years. But of course, we're also interested in looking directly at the sperm of people who have unexplained infertility. We're looking at sperm sorting techniques. And one thing that I'm really interested in is to see how much sperm DNA repair can be done by eggs. Understanding the exact test, because it's a little bit different from the other tests that are around, we can give you 3 different parameters. We can tell you the average amount of damage that there is per sperm across the sample. We can tell you about the really bad damaged ones, and we can tell you about the healthy ones. And the healthy ones are the ones which are very much like those of a fertile man. And we know from our studies that high DNA damage leads to increased risk of infertility, lower success rates by IVF, and an increased success rate by an increased risk of miscarriage, excuse me. So all the studies that we have done and the results we have are generated to an ISO 13485 certification, and our lab is also working towards an ISO 15189, which we hope to get very soon. But the interpretation of any of the results and the management of the client is always performed by the referring clinician. We're delighted to be able to tell you that over the last few years, there have been huge steps forward in terms of the recognition of sperm DNA testing. And this has been recognized by the European Association of Urology. And it's also been recognized by ESHRE in terms of looking at DNA damage in couples with recurrent miscarriage should be considered. And this has changed a lot from 4 or 5 years ago when we thought maybe it could be considered. But now, because there's so much more evidence in the last 5 years, it's now being categorized as something that should be considered. The American Urological Association and even the ASRM are all saying now that in couples who have failed ART or recurrent pregnancy losses, 2 things should happen. First of all, the male partner should be investigated and evaluated by a male reproductive expert, like a urologist, and also consideration should be given to these men to have sperm DNA fragmentation as well as a semen analysis. And then, of course, one of the most exciting things for us was in WHO last year. In chapter 3, we have been brought into the extended examination now. We're not just a research tool, but there is this consideration that DNA damage is something that's really important in the workup of a man experiencing infertility issues. Now, to get to the important part of tonight, to talk about Chris. Now, you've already heard a little bit about him from Eileen. He's a fellow of the Royal Society of Edinburgh. He's been a member of the HFEA. He's on the editorial board of the WHO manual, and he's been on the editorial board of numerous prestigious journals. But what we want to talk about tonight is this global initiative on male reproductive health. So important and so neglected. And Chris has put a huge amount of effort into bringing this together. And so there's no better person to be talking to us than him this evening. So I'm just going to hand over to Chris. The floor is yours, and we're really, really looking forward to hear what you have to say. Thanks, Chris.
Thank you very much for that, Sheena. That's fantastic. I'll just try and see if I can share my screen here. Technical wizardry you need. Share screen. I think that's got it. Is that coming up okay?
Yes, it is. Well done.
Okay, I managed it. Okay, is it okay to start off?
Yeah, away you go.
So I'm going to talk about male reproductive health, I guess, and get a bit of a feel for where we are with male reproductive health at the moment. And in the end, I'm going to talk a bit about the reasons and the global male reproductive health initiative. So I don't think I have any conflict of interest, which would change the message that I would give to you today. I'm employed by the University of Dundee on a one-third contract. I have been a member of the WHO editorial board, and you got a per diem for that. I'm a member of the editorial board of RBM Online. You get an honorarium towards your travel, etc. And I've received some fees for giving lectures, for example, from Cooper Surgical. I'm an editorial board member of the Physiology Reviews. That's non-paid, and I'm a member of the Scientific Advisory Board of the Population Council, Exentia, which is a drug discovery company, and Exceed, who work via trying to develop a sperm test, and that's all paid to the University of Dundee. So it's a plug. It's nothing like a plug for a conference on sperm, but this is an ESHRA campus workshop. So those of you who are interested, hopefully you could join us to talk about male infertility and what we can do in the future about male infertility, and that's in October 2022. So where am I coming from? You know, I know it's late in the day, so I'm not going to give you heavy details. I'm just going to try and get you to think about a few things. So one of the things I want to try and talk to you about is an illusion. I'm using it as an illusion. So I call it the Dolce & Gabbana illusion, really. And these are two papers that describe that illusion and what might happen in the future. And then I'm going to sort of say, well, why do we need to be worried about male reproductive health? Why am I getting excited about the future of male reproductive health? And hopefully I'll be able to discuss that with you as well. So let's deal with what I call the illusion. So at this moment, if we look at reproduction and assisted conception, for example, there is absolutely no doubt whatsoever that this is an incredibly dynamic billion-dollar industry, which has just transformed, global lives, basically. There's been millions and millions of babies born from a series of different ART techniques. And these are all relatively new developments in science, so to speak. So it's a fantastic thing to be part of. Not only that, we've got a number of societies that have grown up and developed, ESHRA, Aspire, ASRM, etc. And they have regular conferences, and there's thousands of people before the pandemic and hopefully after the pandemic attend these conferences. So if, for example, there's a picture on the right here is of the trade stand at ESHRE, and it's literally like, or what I'm familiar with is a quite an expensive car showroom. You know, there's loads of booze and industry, for example. So it's incredibly exciting to have this mix. And one of the things I think is really exciting about reproduction is the link between industry, academia, and healthcare. And this is an incredibly powerful thing. And Sheen has mentioned that, of course, and an example of that as a development. In addition to that, there's some fantastic science going on. You know, single cell sequencing of sperm and in vitro generation of germ cells is, you know, going to blow us away. There's no doubt of that. And the other thing that I think our discipline is, I take it for granted, but I work in a department of cardiovascular and diabetes, et cetera, and some of the people there really struggle to get traction with the public on particular issues that they're doing as scientists. We never have a problem with that. You mentioned babies, reproduction, IVF, bang, the press want to know about it. So there's instant translation of your messages. There's tremendous interest in reproduction. And, you know, this gives just the Economist Sex and Science, for example. So there's fantastic translational stuff. So I guess on the one side of the coin, you know, life just could not be better. And I feel blessed having been brought into reproductive medicine. I genuinely excited about it. And feel very lucky to be really on the start of the curve for some of this stuff. It's fantastic stuff. So on the flip side of that, I think that there are some challenges that we face in male reproductive health. So the reason why I would say that is that if we look at the veneer, everything looks good. But if we dig a little bit deeper under those questions, there are some challenges that we face. And I'm using information here, and I'll discuss these from the WHO. So they did a paper looking at basically a working group trying to work out a future in male reproductive health, mainly from the diagnostic point of view, and then the challenges that are facing. And the ASRM did a diagnosis and treatment of infertility in men, and recently published Infertility and Sterility. And the common theme amongst these papers was some great science going on, but actually we need much higher quality information for some incredibly basic questions. So I've just put these as examples of questions on the left. We don't really know, using recent high quality information from geographically different populations, the real incidence of male infertility. One of the data we use is lots of historical, and there's lots of issues with that. We still have a debate, and Sheena's been present in this afternoon. Is there really a decline in sperm counts? You know, this question's been going on since the 1950s, believe it or not. So if you trace it back, it's the 1950s it started. So, you know, that was, I wasn't even born then. That's how long ago it was. So we're still discussing Barratt treatment. Semen analysis quality, you know, can we count sperm? You know, that's an argument that's going on and on and on. And even something, what I would have thought would be dead simple, like let's look at the reference values of fertile men for the future for the WHO. We only found data from 12 countries. I mean, it's just bizarre. There's just not the high quality data there. And if we have a semen analysis, there's no robust diagnostic tools that are available that are done with a semen analysis can say, yeah, it doesn't fertilize. It's on a routine level and not for more complex treatment. And that forces the field sometimes to sort of do things that perhaps it wouldn't. And really, there's a lot of poor quality studies that have been identified by the WHO panel and by the ASRM. And, you know, the flip side of that, we still don't have a male pill for contraception. We've been talking about having a male pill for contraception. It's been coming in the next 5 years, for the last 25 years. We still don't have one. So, you know, I think we need to move on. I will give 3 salient examples where I think we really try and drive home the points that I'm making. One of them is quite topical, I think, is the challenges of oxidative stress. So how do we best manage, how do we best diagnose, I guess, oxidative stress? And I would just use the example from John Aiken here in his Human Reproduction Open paper, saying there seems to be a lot of different tests about, and the question is, you know, there seems to be rampant uncertainty. I think those are the words John used, in how clinicians can actually best diagnose oxidative stress. And the reason why that might be important is because in theory, if you've got oxidative stress, then maybe the man can have antioxidants as a treatment. And there are many of these on the market, for example, that are available. The problem is, if you can't diagnose the problem well, or you can't always diagnose the problem well, when you then give antioxidants, then are you really going to get around that problem? And then are you going to then increase live births, for example? And this is a very recent 2022 Cochrane review that basically comes to the conclusion we need more studies. You know, we don't have high quality studies using assessments. So the author's conclusion that, you know, there's very low certainty of evidence from, you know, a remarkably small number of trials suggesting antioxidant supplement may improve live birth rates. So, you know, back to the drawing board type of thing. But that conclusion was pretty much the same as it was like 3 or 4 years before that, and 3 or 4 years before years that. So that's my point. The point is that we're not making the progress that we really should be making. And let me give you a classic example of that. So in the UK, we are incredibly fortunate in having a clinical research network, a very, very strong reproductive network. And in fact, actually, if you, and this is data from 2017, but if you look at the accrual of patients per network, and this is included in primary care, cancer, mental health, etc., you see that actually reproduction recruits a massive number of patients to clinical trials. It's a fantastic recruiting tool. So then you think, well, there must be lots going on in male infertility then, because, you know, we recruit the most patients. Not so, because reproduction and child health, it covers females, it covers preterm birth and reproductive medicine, etc. You could argue that there was one trial, which was HAB Select for the 2016-17, but there's just one. So they're just not the availability of clinical trials. And myself and Sheena were talking earlier on about a call by NIHR to then, you know, do more trials, and you know, that ended up as a rather bit of a damn squid. So basically, the activity in clinical trials in male reproductive health is not there, even though reproductive medicine in a global sense, or reproduction and child health, is a very strong recruiter to trials. So I think that that should send alarm bells for us as reproductive biologists, as our ability to address these issues. We seem to be asking the same questions time after time after time. And if we don't change the way we do stuff, we're going to be asking the same questions time after time. Of course, there's that famous quote to demonstrate that. So basically, I think we need to think slightly differently on what we're doing. And I think most people would come to the same type of conclusion now. And one positive aspect of the pandemic, and there are not many positives, but one positive aspect, I thought, from a scientific and a medical point of view, was that it clearly demonstrated to me that if people collaborate, different research teams from different countries or different units, and sometimes they're you know, they can be pretty competitive, these scientists. But if you can get them to collaborate a bit, and you give them enough money and support, there's that caveat, then they can make fantastic progress. You know, fantastic progress to chart, not only to get it a vaccine, which was amazing. I was so grateful to receive the vaccine, you know, almost, you know, 14 months after they started work on it. It was incredible. But now there's so many drugs that are available for COVID, and there's been a massive change in drug discovery for COVID, for example. So we can achieve so much more when we work together, and that is a breathtaking example of doing that. So let's try and do that in reproductive health, for example. So myself and a friend and a colleague of mine, Chris de Jong, who's here, he's wearing a tie, he doesn't often wear a tie. But myself and Chris, we're sitting down and we thought, we need to get coordinated here. We did this slightly before the pandemic, but many people have talked about trying to coordinate reproduction better. This is not a novel idea by any stretch of imagination. But what we did was, I guess, we pulled people together, myself and Chris. So we've got a group of about 12 or 13 people for the Male Reproductive Health Initiative. And we're lucky to get funding from ESHRA to sort of try and get some papers together and do some travel and do some meetings, etc. And the purpose of this collaboration and this get together really is to try and get a strategy for male reproductive health, which is a global strategy for male reproductive health. So I won't bore you with the details, but we published a few papers that outline some of the things that we've managed to do. So actually, when you're trying to develop a strategy and find out where the future comes, sort of discipline, etc., it's not rocket science. Basically, you work out, what are your questions, what are your research gaps, and you basically try and fill those. So we thought that we copy what other people have done. There's a very famous example in exoplanets, which are planets outside this, so are outside Earth, basically, and they've done a whole roadmap of how you would study these. So I thought, well, that's great, we could just follow that. So we developed a series of basically documents trying to develop some roadmaps and ways forward. But there were some key, when we were doing this, it struck me and when we were talking about it, struck me there's two really big issues. Well, there's three really big issues that were facing us right head on. One of them, and we can maybe open this to discussion, but one of them was that the quality of information for the general public in male reproductive health is appalling. It's appalling. So, for example, you ask the normal guy on the Dundee High Street, something simple, with as you get older as a man, does your reproductive capacity change? No. That's probably not true. So, it's just bizarre that and then you've got all sort of funny information that comes out on the internet. So that's clearly a massive area that needs to be dealt with. And then Chris has done a questionnaire and got some information he's just put in for publication on that. And we'll present that in Budapest and then ESHRA in Milan. The other real driver that we discussed a lot was, if you get a bunch of scientists in a room, it doesn't take them 5 minutes actually to work out what are the scientific questions and how we might address these. And if you then say to them, look, don't worry about money. Don't worry about getting money. We'll give you all the money you need. Obviously, first of all, they don't believe you because they're so programmed to thinking about money. They'll come back to you and say, well, but how much is available? You say, no, just get on with it. Get on with it. If you do that, they've cracked it. So they getting roadmaps and experiments to be done and stuff like that actually isn't actually that difficult. And then you can then inform policymakers. But you are come up, if that's the proviso, there's lots of cash available. Here comes the nub of the story. And this is where I think there's a massive, a massive problem. How much money is spent on male reproductive health research? So when we were discussing with scientists, why are there so few clinical trials in male reproductive health? Why is we still asking about sperm counting, et cetera, et cetera? Why haven't we made dramatic progress on A, B, or C? They'll come back and say, well, there's no money in the field. Can't get any research money. So we went, enough people told you that, you've got to listen to them. So we went to the research councils, for example, in America, US, and Australia, and we tried to find out how much money being given, funded for federal funding, government funding for male reproductive health. And it turns out it's been really low. And I don't know if you can see some of these figures, but $0.3 per capita compared to $14, $15 per capita for general research commitment. It's really low. So then we drilled down into this in a bit more detail because we thought, well, is it male reproductive health or is it male and female? Is it actually reproduction is the problem? And that was a really interesting result to me. So we just published, Eve Gamero, myself and Chris, just published a paper in Human Fertility, which basically looked just at the United States and just looked at the UK, and basically looked at male-based and female-based research, and then basically said how much money is given and what's the distribution. And interestingly, the grant is sort of the same. There's a few outliers, but they're sort of the same. So the same amount of money is given per project grant or per program grant or whatever for male and female. And actually, the amount that's given for men, for female and male, is not greatly different. It's 1.5 in the UK and 2 in the UK and 1.5 ratio in the US. It's not dramatically different. The real problem is that for male reproductive health, less than 1% of the funding of government federal funding is given to male reproductive health. So if we think there's 1 in, 15 men or 1 in 7 couples who are in first, just even look at that figure. 1% is not scratching the surface. So there is clearly an issue about delivery of the funding for the research. So part of the remit of the Male Reproductive Health Initiative, etc., is to try and increase this amount of funding that's coming. But and what I was talking to Sheena earlier on was the key message that we thought was, we then went to the policymakers and the funders and said, look, you're not giving enough money for male reproductive health, even reproduction. You're not giving the money. There's something wrong. Why are you not doing this? Why are you biased against reproduction? Without fail, in 3 different countries, they came back to us and pretty much gave us a message that there is no limit on what money you can get. The issue is you're not putting in enough grants, you're not putting enough high quality grants, and you're not coordinated enough. And that really is a very strong message that came from NHMRC, came from Wellcome, came from MRC, and it came from NICHD. And when you talk to the program managers individually and say, look, okay, do you tell that to everybody? No. That your problem is in reproduction. You're not lobbying hard enough, you haven't got the right, etc., 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 etc. So actually the problem is us. We're the problem. And that really hurts, I think. It's not nice to be told that you're the problem, I guess. But that's a positive thing because we do something about it. It's not an impossible thing to do about. So part of the Male Reproductive Health Initiative is to try and raise this awareness and collaborate and try and get different groups from different parts of the world. So you'll notice now that Healthy Male in Australia, that's the only country really that's got an andrology or a male reproductive health effective network, and it's federal funded for about $3 million, Rob and Moira have said. So, and they've got this really well established, and it's a really great start. But it's only Australia, there's 192 other countries in the world, EU Costa, Raphael has got a EU cost coordination for andrology for Europe. That's mainly education and research. That's not actually awareness and driving the field forward in that way. But it's a start. So I think there are little bits starting around the world, and the part of the ESHRE and the Male Reproductive Health Initiative, we're trying to help and drive these things together. And that's part of the purpose of going to Budapest and going to that thing. So that's, I think, a really important thing that we're trying to do. But I think we need to think of a step above that. And these are just examples, okay? This is just a thought process of examples that I would use. So one of them is the Wellcome Leaps program, for example. My colleague, Jason Swedlow, runs one of these Wellcome Leap programs. And that's £55 million just to sort of fund one part of the program. And so therefore, can't we think of something of reproductive health of that sort of quantum level, which is done in the UK as an example? That's the way we need to think of reproductive medicine. That's the way to think. Otherwise, we're going to be asking the same questions. You look at the NIH and the Brain Initiative, for example, millions and millions and millions of dollars are put into this and networked, and they're guided in network. You look at the Bill and Melinda Gates Foundation, they're funding contraception, for example. and there's millions of dollars going to, and it's coordinated. And this is, to me, this is really something important. So it's going to higher levels of funding and showing coordination and then fitting with other disciplines. But in addition to that, there's probably different ways of doing science. So I use the one example from James Nichols in the middle here, which is PNS paper, which was talking about doing science slightly differently. So it's coordinating the science as well, but then adding the evidence brick by brick. So not starting again and not one group doing one and the other doing the other, and it's not fitting in the same wall. And the evidence is put together in a collaborative way like that. And that's a new way, I think, of trying to deal with different groups and hypothesis testing development. And in fact, and this is the comment on the right is from Nature, and that was basically looking at a way of trying to think of how to do big team science differently. And it gives the example of psychology, where they've gone from various different ways of doing research and then coordinating groups together. So I think we need to go a step further in what we're doing and use these as examples of ways of developing for male reproductive health. So in my summary, we can't be in 5 years' time asking the same stuff. That's gonna kill us off, I think. We've got to behave and think differently. And I think we have to accept, and I'm quite happy to be disagreed with, but we have to accept, I think, that actually we're the problem. We are the problem, and we need to deal with it. And it's a we. It's that's the part of putting stuff together. And I think reproductive medicine, reproductive biology, reproduction needs to up its game logarithmically. And if it does that, I think we will start to get answers to this, and we will start to have a much flood of young people coming into the discipline, which is of course what we want. I'm old, and I'm used for the scrappy basically, but what we need is young people coming through and driving stuff. But they're not going to come through unless A, they're excited, B, there's some cash in front of them. So we need to put those things forward for them to come forward and do stuff. So I'm very grateful. I haven't showed much data today. Hopefully it's been a bit of a whistle stop tour rather than data science. But I work in Dundee, and I'm very grateful to all the collaborators that we have, Sarah and Steve and Ian and Ian and Jason and Kevin, who do the drug discovery, and the Bill and Melinda Gates Foundation. And I'm very grateful to my colleague and friend Christy Young, who developed the Male Reproductive Health Initiative with, and he's given a lecture in Milan in ESHRE about the global initiative. So I'll just leave you with the last slide. Say look forward to seeing you in Milan, and also look forward to seeing you in Budapest for the ESHRE campus workshop. I'll stop sharing now if I can. Thank you very much.
That's fantastic. Thank you so much, Chris. That's absolutely wonderful. I mean, it is a strategy which we need to adopt. And like you, I feel very prickly and very hurt when people say we're the problem, because we've been struggling for so long to actually be part of the solution. But I wonder how you think we're really going to tackle it. I mean, how is it that we're going to make the public think that reproduction isn't as important? I mean, at the moment, the NHS is completely swamped with diabetes, with aging, with Alzheimer's, with cancer, and we are such an insignificant part. And so many of our colleagues, even other clinicians, would say, well, people are infertile because they wait too long to have their children. It's self-induced, it's a lifestyle problem, and there's sometimes not a lot of sympathy for people who have fertility problems.
Yeah, no, I don't doubt that it's a mountain. It's not a molehill. I think that, and so it's always good to recognize the scale of what you're trying to do, I think. So I just think there's no alternative. But I do think we have a general problem in reproduction, in selling, for want of a better word, of how important reproduction is. If you get an elevator speech for reproduction to an investor or something like that, then we need to have almost it sounds pathetic in a way, but we almost need to have bite-sized chunks of why reproduction is important. And from that, then the important thing is then we can then start to hive things off. So when you talk to influencers or whoever, whatever they call themselves, they'll say you need, those messages need to be incredibly clear.
Mm-hmm.
And I don't think we have those at the moment. So I think that's issue A. And issue B is although there's a lot of public interest in the discipline, there's not the groundswell. It's got to come from the ground up as well. So I think that's, we've got to meet those two. But as a discipline, we've got to drive, why is reproduction important? And we need to bite size that off. And that's going to be probably a 5-year drip feed program. If I walk down the corridor in the cancer, I'll give a very simple example. I walk down the corridor, the cancer people, so the cardiovascular people, and they say to me, oh, cardiovascular costs X as a global burden disease, $1 billion thing. They say for diabetes costs X. What's the cost of male reproductive health? I don't know. Well, you must have a figure. What's your figure? I don't know. I can tell you how much ICSI's done, but that's not the same. But what is the cost of male reproductive health? I said, I don't know. I said, well, you're dead in the water, mate. Nobody's going to give you any money.
I know if you don't. And yet, as you and I both understand, the comorbidities that are associated with male infertility, male infertility, the kind of testicular cancer, as Sarah was talking about earlier in the ARC seminar, the relationships with later onset diseases.
Yep.
So many things. I mean, one of the things.
But give a dollar amount to it. That and it's got to be an intellectual. It's got to be an intellectual exercise.
Yeah.
If we could do that, then that would help us, I think.
Yeah, we had a decent business case. The other thing that I think we need to do is we need to start talking to young men, even secondary school children, about their reproductive health. Because the man in the
agree.
Was exactly the guy, because he thinks that Mick Jagger had a child when he was 80, there'll be nothing wrong with his reproductive health either. And this is a complete misnomer, that because celebrities all have much younger women who can sort out all the problems with their sperm. But we really, really need to be telling the population at a much younger age how important it is. And when you think about our aging population, you think about who's going to pay for the old people like me when we're in our retirement homes. There's so many less young people coming on. I mean, this is an issue in Italy now. There aren't anything like enough younger people in the workforce, which was predicted for 20 years. What are we going to do about it? How are we going to actually engage with the population at large?
No, that's one example that was given to me about cost. They said, well, we need more taxpayers, in the future. Scotland's got less than 1.5 as a fertility rate. We need people. You work in reproduction. So but we've got to marshal those arguments and build that, and we haven't done it.
But it's a massive public health issue. It's not just an individual couples issue.
Exactly. But again, it's helping people understand that.
Yeah.
And we as a discipline haven't done that very effectively, I think.
No, I agree with you.
That's my hypothesis.
And I also think we've been small-minded. If we got 50 grand for a research grant,
we're excited. Yeah.
We thought that was really good. And so did our university. But actually, if you're going to put a grant application together, we should have every andrologist in the UK on one application, and we should be asking for £5 million.
Yeah, exactly.
So we should
exactly.
And I think what you're saying, a different model, and you are one of the leaders in this area, and I take my hat off to you, because I think you really are showing us the way to go, and we'll be nothing but fools if we don't follow your lead.
I think it's the way to go. Personally, I think we have to sort of accept that, we need to do things slightly different. Anyway, I'll stop talking.
Well, we've just got a couple of comments here thanking you for your talk and how much they enjoyed it. So I think it's almost time for us to end now. If anyone else has time for you to go and have your dinner, no doubt. No, I don't think there are any further questions. Someone's asking if they can hear this webinar again. Yes, you can. in 24 hours, it'll be online, and you can hear this webinar, and you can hear all of the previous webinars that we have had. We're not going to have one next month because we'll all be in Milan at ESHRE, and we will have the next one in August, and you will see all the details of that. It's John Sullivan, who is a urologist who's been in the States. He's been working with Dory Lamb. He's very interested in DNA. He's coming back to work in Ireland, and we have big plans to work with him. And he is going to talk to us about his plans for the future. And so come along and join us. You'll get all the details on our website, and we'll see you in August. And until then, have a happy and safe summer. And thanks for joining us now.
Thanks very much. Thanks a lot. Bye. 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 See you, Sheena. Bye. Bye.